Good morning, everyone. I hope you are enjoying breakfast, recovering from last night's festivities. Some of you look a little worse for the wear, but we're glad to see you. There's plenty of coffee. We'll keep the coffee and water going all morning, get some carbs, and get ready to enjoy a great day. My name is Julie Wilson. I'm with Healthcare Realty. Stephen Stubbs and I are co-chairing the conference, and we are glad to see all of you on the last day of the MOB component of our gathering. I think a number of you are staying for the lab portion, so that's exciting. We're going to get things started with our Healthcare Ambulatory Strategies panel. I did not have too much to drink last night. That is not rolling off my tongue. Moderated by my dear friend, Lori Damon. They'll get started in a moment. A couple of housekeeping items. Revista is going to send around a survey after the conference. We really would like your feedback about panels, logistics. We modified the schedule a little bit this year to start later on the first day and moved the golf outing, so we'd like some feedback about that. Would also like some feedback about panels that you'd like to see. We've gotten some great feedback about some of the things that we've done. Yesterday we had a debt panel. Today we're going to focus on equity. Hope you will be there for that. And at lunchtime, of course, we are going to recognize up-and-coming folks in our industry and make some awards for lifetime achievement. So that's always fun and exciting and a great lunch. I think that kind of covers the housekeeping items. Glad to see everyone here this morning. And Lori, I will turn it over to you.
Okay, terrific. Thank you, Julie. Thank you, everyone, for joining us this morning. I want to spend a minute and have our panelists introduce themselves, and then we'll get right to it. So, Kelly, please explain who you are and what your job is.
Perfect. Good morning, everybody. It looks like church in here, so glad to see everybody moved all the way to the back. We can't see you, though, so all is fair. Kelly Knoll, I am Vice President of Construction, Real Estate, and Facilities Operations at UPMC, based out of Pittsburgh, Pennsylvania. We are a 40-hospital system, about 41 million square feet of assets, domestic and international, so have overseas hospitals as well. What else do you want me to say?
I think that's good.
Okay, that's what I do.
Hey everybody, I'm Steve Barry, Executive Vice President of Facilities Management and Real Estate Development at RWJ Barnabas Health. We're New Jersey's largest academic health system. We have 12 hospitals spanning 8 counties and treating 5 million patients a year. And I oversee planning, design, and construction, facilities management, and real estate for the health system.
Good morning. My name is Terry Wood, and I lead facilities, design, and construction. I'm still learning that word. We rephrased it last week. So we are a fully integrated healthcare system with the insurance, the doctors, and the facilities. We have a presence primarily 83 to 85% of our business is California, but we are certainly in other states, including Oregon, Washington. We're in Hawaii, Colorado, Mid-Atlantic states, and Georgia, and we have just developed a wholly owned subsidiary called Risant, and we're about to close on a system from Pennsylvania as well. And don't ask me too much about that one, because it's a little confusing, but yeah, so, and as I say, I lead the facilities design and construction.
For Kaiser.
For Kaiser Permanente.
Small little organization.
Not just Kaiser, Kaiser Permanente.
So terrific. So we're going to go through a couple of questions first, just to kind of make sure we're all on the same page in terms of terminology. And then we certainly invite your questions at any time. And I believe that there's a microphone right here. So if you have questions, come up and ask or gesture wildly from the back so we can see you through the stage lights. So with that, we're going to begin. So let's start with just some fundamentals about how health systems think about ambulatory strategy. And primarily, it's developed in terms of what it is not. So you have inpatient and you have outpatient. So let's begin with those fundamentals. Kelly, what is the percentage of revenue for your system that comes from inpatient versus outpatient?
We are 40% inpatient, 60% outpatient right now.
Okay. 40% inpatient, 60% outpatient. Steve, what about you?
We're the inverse of that. So we're 60% inpatient, 40% outpatient. That could be a bit misleading. We have joint ventures that the revenue is not consolidated on our balance sheet. So if you included that, we'd probably be closer to 50-50.
But once upon a time, just as a data point, in 2009, at a BOMA conference, one of our health system speakers pointed out that their revenue at that time, and they were a very large system that operates in more than 20 states, and their revenue was 70% inpatient, 30% outpatient, and the goal was to get that to 50-50 by 2030. So consider what that horizon looks like now with what you have just said. And Steve, you made a good point. There's murkiness in this data. So even when you see that split, it doesn't necessarily tell the whole story.
Correct.
So now, Terry, we're going to talk to you because you don't actually measure it this way. So how does Kaiser think about this?
Well, we think of total care. And, as an insurance company, we provide, inpatient, outpatients, whatever's required. So, to serve our members. The way we think about it, well, in terms of percentage by square footage, we have 40 hospitals, and we have about 650 medical outpatient facilities. Did I say that right? Okay.
Trying to be very careful about avoiding a certain other O word.
And I would say it's 35 to 40% are inpatient. Is inpatient by square footage. But we don't capture the revenue that way. We capture our revenue through the insurance revenue. Our members, we've got 12.5 million members. And what we look at is how do we do it most cost effectively. And without those inpatient facilities in markets where we don't have them, it's pretty hard to make a profit. On the other hand, we can't justify $2 billion to build an inpatient facility. So we think of it more in terms of how do we deliver that total care, not on a revenue basis.
Right. But as an insurer, presumably one of your goals would be to keep patients out of the hospital through effective preventative care.
Absolutely.
So a different business model than either Kelly or Steve is working with. Okay. So would you say, and I think I know the answer to this, Kelly and Steve, would you say that the balance of outpatient versus inpatient is increasing or decreasing in terms of your revenues?
Definitely increasing outpatient.
Sides of our business are growing, but outpatient is growing disproportionately fast.
Faster. Okay. So let's next begin by talking about, we've got two buckets, inpatient and outpatient. And so when we're thinking about ambulatory strategy, let's begin by defining our terms. So Kelly, I'm going to start with you. What actually is ambulatory in your universe?
Oh, geez. This is like a dissertation. It can mean so many things. It is not building a bunch of brand new surgery centers to support the existing patient volumes. Ambulatory to us is maximizing utilization of our existing assets. It is doing better with timeshares. It's all of those other things. Of course, there's some building, but that's ambulatory.
Okay. What about you, Steve?
So I think it's helpful when we think about ambulatory to think about where we've come from. And, for our system, 10 years ago, maybe even 5 years ago, it was much different. It was a very hospital-centric vision, and everything's built around a hospital business plan. And as the system grows over time, and we have 12 hospitals, where do you end up? You have 12 business plans, right? Yes. You have 12 strategic plans. When you think about it, that doesn't make a whole lot of sense. When you think about systemness and where we're trying to head to provide the most efficient care and convenient locations. So we've really shifted away from that, and that's not just talk. We've actually restructured the health system with a focus on regional and service line approach. So we're taking that away from the hospitals and looking at the entire community that we serve and how can we most efficiently deliver those services in a convenient way in the right location to those patients. So to me, I think it's worrying less about the competition, paying more attention to the patient, and what they need in that community and what are the services they need and how can we deliver those services. I think if you follow that, you're going to have a good ambulatory strategy.
Okay, and what about you, Terry? Go ahead. Yes, please.
So Steve, you mentioned moving out of the hospitals. Are you using different leaders to execute the ambulatory strategy?
We are. So we have a whole new leadership structure where you have a clinical and a business lead for each service line. So cardiology, we're looking at across the entire system. How do you deliver cardiology for the system regardless? You don't have a hospital CEO saying, I want to place this building here. That's completely gone.
I think that's probably one of the most important things about ambulatory is we've tried to put hospital leaders in charge of ambulatory, and it's perpetual failure, right? We just make them little alert hospitals. So putting leaders who know how to get the throughput in place to run ambulatory is the key to actually make it an ambulatory. Otherwise, it's just another building, not called a hospital, that functions exactly like it.
So one of the measures of ambulatory strategy in your world is really focusing on throughput, not just we have a site here, 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 and here. We're looking at what's going through those sites and then where it's ending up and what else it generates.
Yeah, I think Kelly mentioned it. The lowest hanging fruit for us is not to go out and build a bunch of new buildings. It's to rationalize and reposition the existing network and make sure that those facilities are utilized appropriately. And when you grow through acquisition, you go into a specific market and you look at it, you would never set that up and say, oh, let's put 5, 1, and 2 provider practices in this market, right? You would never set it up.
We'd never do it that way.
You would never set it up that way. In a bunch of suboptimal real estate. So how can we
Owned by the physicians.
Right.
Correct. Converted homes and other real estate that's not reflective of our brand. So how can you optimize the existing network? Obviously look for opportunities for growth as well. And look for those facilities that they have more opportunity for utilization that is not being tapped into.
Terry, what about you? How do you guys think about ambulatory strategy?
We don't really think of it much differently. I think we certainly focus on where our members are residing and making sure that we have capacity and drive times that support those members. We do look at opportunities to decant from hospitals inpatient, obviously, where it makes sense. And sometimes we'll create an MOB just to do that, that's close to the inpatient facility. But we do have an entire group delivery system strategy within each of our markets that are, those groups are managed centrally that use the algorithms of where our members are to support them first, and then where we're considering growth in new markets. And that's really what drives, and ambulatory is everything that isn't inpatient. The physicians don't drive that. We make a clear distinction between the health plan, which owns the medical facilities, and the physicians, which are for-profit. We're not for-profit, they're for-profit. But we couldn't do it without them, obviously, because they have the expertise to help us with creating those facilities and what's in them and whatnot. But we're clear that we are making the decisions on them, and they do have to support the health plan as a whole, the growth of the health plan. And then we partner in terms of creating it, delivering it, designing it, et cetera.
Right. So one of the, just to help us kind of frame this discussion, I pulled some data from the advisory board's outpatient and inpatient market forecast. And so I have the 5-year inpatient growth, and you can see, right, rehab is growing the fastest over 5 years at 16%. If we look at 10%, right, you've got rehab, neuro, other trauma, invalid. By the way, I had to call them about this. This is everything that's miscoded or doesn't have a code or gets billed something differently on the back end. I think it's comical that this is actually growing by 20% over 10 years. Apparently there's a real need for better coding. But if you look at the difference, right? If we compare this just to outpatient growth, nearly everything is growing in the outpatient sector over the same horizon. And so on the one hand, this is not new news to anybody in this room, and it would be very easy to say it's time for a victory lap, right? All of this points to more great work for all of us, except that it's not quite that straightforward. And Kelly, you said a word that always strikes terror in my heart, and that word is timeshare. because that is an important part of strategy, but it is not a very fun type of real estate for anybody in this room to contend with. So let's talk a little bit about why this isn't all sunshine, rainbows, and puppy dogs, these stats.
Well, I mean, we started the conversation. It really is utilization and optimization. So those are two drastically different things. The first is we look at utilization, and we average 33% utilization of any of our assets. So if you just want to talk about getting that to 50% or even 75, I don't need to build anything. I just need people to do work. And then we still don't have good throughput. It should all be done faster, so there's more capacity, and nobody works Friday afternoons or nights or weekends. So you have all of this capacity that's not being used, and we just need to figure out how to do it. I mean, that's the reality of it. You said it too, Steve. Every doctor you acquire is 2 or 3 exam rooms and these really bad real estate deals. So if we can consolidate those and get that together, that's where I talk about timeshares into these larger facilities, is you get 2 days a week, and really that's all you're doing in volume anyway. So it shouldn't be. I know it's scary, but we're going to do it.
Right. Well, I'm curious though, how do the physicians, how do your clinicians respond when you come in there armed with your 33% utilization stat and they really want a new building?
That can't be right.
1,000.
I'm way busier.
Never been
than
right.
that. Right. Yeah, no, I think I'd go back to the service line structure that we have now. The service line leaders have really robust scorecards and data, and I know you're on Epic,
yeah.
right? We've transitioned 100% of our sites. We've grown through acquisition, both physician groups and hospitals, and that's been quite a journey to get on one medical record. But once you get there, you've got a lot of powerful data, and so by service line, they've developed very robust metrics to measure how busy and productive these practices are, and so it's pretty hard to argue the math when you sit with them and say, let's look for ways to better utilize the space that you already have.
But it takes strong physician leadership. That's not the real estate team to be behind you supporting that dialogue. Correct. That's the most successful conversation is, who are you, the real estate person? Don't tell me how to do my job. But when you have an executive physician leader who can come in and talk about how they're doing block or how they're not doing block and what these time slots should be, that's the most productive outcomes, is you have everybody at the table having that dialogue.
Right. Terry, for you at Kaiser, right? I mean, this has always been Kaiser's stock and trade, right? As an insurer, you understand utilization and have been ahead of the pack in terms of utilizing that. How much does utilization metric matter in your ambulatory strategy planning?
I would say pre-pandemic, it wasn't that important. I mean, I don't know if there's media in the room here. I don't want this to get back, but
Okay, Marie, don't write that down.
The story previously was, if you wanted an MOB to go through, take it to the capital approval committee, and if it didn't get approved the first time, take it back a couple more, it'll get through eventually. Not the case anymore. Post-pandemic, we're paying much more attention to throughput and utilization, much more attention. We have the most control over our operating costs through the capital that we hold centrally. And so that's what we hold close to the chest. And now, I mean, medical office buildings, they're not just not getting through capital approval, they're being downsized through that process as well. So we are taking a much closer look at it. And we are working with our physicians, around increasing throughput, increasing utilization. And the other thing that's impacting that is we have 4 hospitals in the pipeline for California alone over the next 3 or 4 years. So that's $8 billion right there. So we're just doing a little more.
So some of your capital is going there, but
it's not growth.
It's not growth, right? Those are replacement hospitals, and it's seismic driven.
All seismic.
Okay.
All seismic.
But Kelly, a lot of your budget, and Steve, a lot of yours, frankly, are going. A lot of the money's still going into inpatient, even though these numbers are what they are. So how do you navigate that when you have to grow ambulatory, but you have aging facilities that have got to be replaced? I mean, right, Kelly, you have like a giant capital spend and it's all hospital.
Yeah, so my budget's $1 billion a year, and the line item for ambulatory this year was $30 million.
Wow.
30 million of 1 billion. Right. So it's sort of laughable, but a lot of those projects are there should be very minimal cost to the capital part of the project if you're just changing how you're operating those buildings. I don't need to I don't need to build anything. I just need people to share and cooperate and talk realistically about what they're doing every single day. And we will build, there are projects, but it also takes working through all the data. So Epic, yes, but we actually still have 5 EMRs. We won't be fully onto Epic for 3 more years. And so getting the data cleaned up, having conversations about, I said this, what should the block times be, but what should throughput be? How do we do virtual visits? Do those count? Are we double counting? All of that data still needs to be cleaned and scrubbed so you can get alignment with how you move forward. So we're spending a lot of time continuing to do that right now before we'll have any significant spend on the ambulatory side, or what we're calling dedicated ambulatory. Also reactivating our spaces. We have spaces we moved into the hospital 10 years ago to consolidate for staffing reasons, and now you're going more to those outpatient or medical office buildings that were not being used.
Right. And when you think about, Steve, is your budget similar? Is it much more weighted?
Shockingly similar.
Shockingly similar.
It's over $1 billion capital budget, and we have 50 million.
Wow.
Dedicated to ambulatory. So very, very similar.
And when you're planning ambulatory, if you were going to build a new building in view of utilization and throughput, are you moving toward design prototypes that help enhance that? Or how does that impact your design strategy? Like, how does design get into this conversation?
I think you can have the best prototype in the world in this construction environment and still not going to pencil, basically. We have thought a lot about prototypes. Again, I would go back to really paying attention to the data and the community that you're trying to serve. I don't know that you can pull something off the shelf, but I think you can organize the facilities into buckets where you have a primary care driven strategy. You've got something in between that's got specialty care, some maybe advanced imaging, and then the largest prototype would be a destination ambulatory care center. So I think depending on the market you're serving, they might look a little bit different, but they are organized generally into 3 to 4 prototypes.
Okay. And what's in one of these destination medical office buildings?
Don't say that word.
Destination medical ambulatory centers.
That's right. Yeah, it's going to be everything that you would assume is in there: a foundation of primary care, specialty care, physical therapy, advanced imaging, and ambulatory surgery.
Okay. So 100,000 feet, 75?
They're at 80,000 feet.
Okay, so sizable. Okay. All right, let's talk about what is a successful, I asked each of you, and this was not intended to be a trick question, but they all thought it was a trick question. So I'm going to ask you, can you describe a specific ambulatory project that you can consider successful? And Terry, we'll start with you.
They're all successful.
Every one of them.
Actually, I could spend more time on 1 or 2 that haven't been successful, but I don't want that in print either. So successful, I mean, anything that reduces time, travel time for our members, and that, that's what they're all designed to do. That decants from inpatient, allowing things that need to be done in inpatient to be done, on a larger scale. And as I say, there's only 1 or 2 of the ones. I've been at Kaiser Permanente now for about 8.5 years, and we have 10.5 capital approval committees. 10.5, not 10.5. We have about 10 meetings a year. And, for the first 6 years, I would say, we had an MOB on every one of those committees. So we had, 5 or 6 going through, or 7. As I say, I can only think of 1 or 2 where we got it wrong on the membership travel time, we got it wrong on membership growth. That's probably the area that's the hardest to really figure out. I mean, it's an estimate.
Right.
Just building it there and hoping they'll come is not a strategy, and we've tried that a few times unsuccessfully. But in terms of successful, I mean, because our data and our algorithms are pretty sophisticated and they've been worked through, the they've gone through the test of time. They're it's not very often that they really don't deliver exactly what we suggest. Now, do they deliver the margins that are forecasted when the case comes forward? No. I mean, it's very easy to say in 3 years it's going to, all of a sudden they're going at 3 to 5 to 7% margins, but they're certainly making, they all make money. When I say make money, they're delivering in support of the growth that we've got and that we're forecasting, and most importantly, we're getting the feedback from the members that it's serving them.
Okay. And so as long as the members, right, are satisfied, then that counts as a success.
It does. It does.
Okay. Steve, what about you?
So we talked about the two sides of the coin, one driving efficiency in the existing network and the other looking for opportunities for growth in those markets based upon the demands and the needs of the community. So I would highlight a project where we had both of those factors. So there was a community in Toms River where we had two 20,000 square foot facilities that were outdated, very inefficient, not reflective of the brand. Not great for the patient to have to travel to both of them. A lot of the services provided, patient and their families would have to go to each one. Staffing inefficiencies, right? To have the use split like that. So to be able to consolidate that into one location was a win. You're kind of playing with house money a little bit out of the gate, right? And then we looked and said, what else could this community, serve? And like Terry said, decant some of the inpatient ORs. So we've added 5 ambulatory, ORs into the project, full diagnostic imaging center, new primary care physicians, new orthopedic physicians. So it was that combination of efficiency and growth in a destination ambulatory care center. And I'll give a nod to my friends at Rendina, who I see in the room. The Rendina team did an awesome job identifying the right piece of property, full service development through the pandemic, and we cut the ribbon on it. I would agree with Terry. It's hard to call it a success. I think that's probably not, it's too soon, right, to really say how successful has it been. The consolidation piece is a clear win. The ASC, I think, everybody needs to have a little bit of patience. And I preach that to our leadership, that when you build a facility like this, it's a long-term strategy and plan. You may not blow the doors off day one, but if you have a little bit of patience and let the facility grow, 10 years from now, I think we're all going to be happy we made the investment.
Sure. What about you, Kelly?
I was the one who said this was a trick question. I think we've had a lot of successful projects in certain people's aspects, but I don't think any project has hit the mark in total. Okay. There's always something we need to improve on, and that's exactly what you're getting at. We're not really good at making sure I don't know, somebody's taking notes. I need to be careful here. I just don't think we always have all of the data in every situation, or that we project right where the future is going. And so we were short ORs on the last center we built. It was multi-specialty, which worked out great for the community. It was an underserved community, so there was tons of positives, but we don't have enough ORs for their time, the times that they would like. Again, they could work on Fridays and the weekends, but that's not on the table. It's the thought leaders that make the decisions too, is where we struggle to get the right people making unique decisions, that I think it could be done better.
Murray Wolf's live blogging right now about the UPMC failure. So,
one thing that's changed.
We admit it.
Go ahead.
No, we admit we could do better on some of these things.
One thing that's changed for us is we would overbuild on the assumption that we're going to need it at some point in time, or we would even warm shell places in the facility. We're not even doing that now. We're saying if the site's large enough, and this will last for 10 years, then let's think about an addition on the site if it has the capacity. Let's just, not spend today and wait till the demand is there before we build it. So that's a significant change from what we used to do in the past.
Terry, do you think, and really this is for all of you, do you think that's a function of us coming out of the pandemic, and last year was such a rough year, right? All the PPP funds went away, everybody's operating margins were really strained. Do you think this is an overall change in strategic direction, or a reaction to a tight year. And in 2 years, when things are a little looser, we're going to go back to building warm shell space, and we'll sit on it till we need it, right? Because there's always going to be a rainy day when we need it.
Well, we lost, and this is public information, we lost $7.5 billion in 22. So that does make you change. Whether that means you're going to change forever. When I say we lost $7.5 billion, that's, that we lost around $6 billion through our investments. We lost operating costs around $1 billion. So that does change your direction. And is that going to be for long term? Well, we're still struggling for, to get to positive margins. And as long as we're in that position, we're going to continue to operate this way. If we're back up to where we were pre-pandemic, I still don't, the same people are kind of running the company and involved in these processes. I don't see them all of a sudden opening the floodgates. Well, they weren't opened floodgates, but it was certainly a lot easier to get projects through previously. I'm not sure that will change, to be honest with you, because then you also have to layer on top of all of this what's happening in the industry, what's happening in healthcare, what's changing. And so I think this was a wake-up call for us to really, slow down on these projects and think more about how we're going to operate going forward, and be more judicious about how we spend our capital.
Well, I saw this really interesting stat that healthcare utilization has recovered. So we're back to, or in some markets have exceeded utilization prior to pandemic. So the patients are back, but your revenues are not. And some costs went up. Steve said construction costs, you can't get anything to pencil. Those numbers are up and they're coming down, but are they going to come down to pre-pandemic levels? I don't think anybody's taken that back.
Not really coming down though. All they did is leveled off.
Right. Yeah. And then the other big problem in all of this is that your staffing costs went higher and they're strained. So when you add more facilities, to your point, Steve, then it takes more staff, and that staff costs more. So again, you're back to a deal that's really tough to pencil. And I don't really imagine a future in which the staffing costs, nobody's going to work tomorrow for less than they worked today at your system, I would imagine.
Now, unfortunately, I think both of those factors, the construction costs and the labor costs, I don't think they're pulling back. I'm sure the Revista team has great data on the construction pricing, but the sticker shock is real. We're bringing projects forward, not to mention projects that were budgeted in 2019 or 2020, major projects that were approved. You can't deliver them for what they what the pro forma was built on. Not to mention projects that are in the design phase now, and you're bringing them forward for a capital approval. It's just a drastically different environment in terms of what these projects cost today. And people, internally, they don't believe you. Like that can't be right. It is right, unfortunately.
It is right. And it's up by how much? If you had to ballpark it.
40%.
Yeah.
40%.
Yep.
Wow. So that would explain why the pipeline is slowing down.
You have to be very selective, on where you're going to make your bets. And I think that's probably why we're talking about portfolio optimization and utilization. I don't think, not that.
The future's unpredictable, and healthcare, something's going to have to give, because we can't continue to, everything costs more and we get reimbursed less. Like, we cannot continue down the path, and clearly none of us have that answer, but something's going to significantly change here, or the healthcare system in the United States will be non-existent. So you can't keep hospitals open. We can't have the amount of infrastructure investment that's been deferred for every organization. That is catching up. It has to change. Something has to change.
Or else we'll all be working for Terry.
Yeah.
Right. With any luck at all, right?
We increased our rates this year, and we had a lot of pushback from our members. But you can't, to the points just made, you can't continue to operate at these escalation rates. And by the way, it's not just construction, it's not just staff. It's everything we use in the facility has increased tremendously as well. So inflation hit us everywhere.
Utilities, yeah.
And so, we struggled to maintain the membership we had. We've been growing dramatically. I think we had 8.5 million members when I joined 8 years ago, and we're up to 12.5 now. But it's really leveled off. But as as the points that have already been made, you got to pay for everything. You can't do it on rates that were set before these 40% increases came.
Yeah, when you look at, Terry raises a great point, when you look at the chart of construction price increasing and you compare it to medical equipment, it's a very similar increase. And the facilities that we build, you have to put a lot of equipment. Sometimes when you look at the budget for a facility, it's not uncommon for depending on the facility, the medical equipment to rival the construction
cost of the
budget,
building.
right? So when you're getting hit on both sides from a total project cost perspective, that's what drives this sticker shock issue even further.
And so all the more reason to optimize, and maybe that includes consolidating and enhancing your throughput. But even then, all of you work in large, kind of sprawling, complex systems that cover a wide variety of patient populations. And Kelly, I'm thinking about you in particular, right? You're covering pretty much the entire state of Pennsylvania in your home neck of the woods. Steve, you have 8 counties to cover. Terry, you've got, the West Coast, the East Coast, and some stuff in the middle. How do you serve it? How do you think about ambulatory strategy in a way that is thoughtful for all of those different patient populations? And in particular, it seems to me, given these costs, the equipment and the building and the staff, how do you service populations in less dense areas where they really need it, right? It's not like you just get to say no thanks, right? If you go 50 miles outside of Harrisburg.
Yeah, they just were talking about, there was a news article that said there's 8 counties in northern Pennsylvania that have no medical or maternal care, health care right now. So that's staggering and concerning, and the nearest hospital is over 100 miles. I don't know, there's a lot of that going on. I think the one thing UPMC is doing is figuring out how we can partner with other health systems or independent hospitals to try to help them continue to float. The reality is that when they fail, we just get their cast-offs, their sicker patients, or as they continue to fail. So those partnerships are happening. We've also put some freestanding EDs, so closed the full hospital and put freestanding ED in some of our markets, which has been well received. Obviously, it reduced our cost. We just couldn't continue to carry the cost of the whole hospital when you have 5 or 6 patients. So I think we'll continue to see those unique models, but legislation has to catch up to that. We were the first in the state to have that freestanding ED, and we had to fight really hard to get that approved.
Right, and many states won't permit them at all.
Right.
So, Steve, what about you?
So we don't have.
Jersey's a little more compact than Pennsylvania.
It
but
is. We don't
still.
have any rural markets, I'd say, in our service area, but we have certainly urban and suburban. And so I think it's, to Terry's point, when you're planning the network, you're looking at drive times. In Jersey City or Newark, we're probably looking at walk times, right? And paying attention to the locations of public transit and things like that. Suburban, we're looking at drive time certainly, and it depends on the service you're trying to provide. For primary care, you're going to look at a 10-minute drive time. Specialty care, maybe 20-minute drive time in those markets. So just planning an appropriate network. But I don't have any of the experience on the rural side. I let Kelly handle that for us.
Lots of problems.
Right, and well, Terry, you can report back to us next year once you pick up your
coming in our
partner
market.
in northern PA.
Yeah, but I will say it doesn't have to be rural. I mean, we have a commitment to neighborhoods that we're very intentional about serving. Baldwin Hills Crenshaw, we built a beautiful MOB there. We broke ground about a couple of weeks after I arrived. This is what really inspires me to be in healthcare, to be honest with you, and Kaiser Permanente's commitment. Its throughput is not great. We do have trouble having physicians work there even, but we're committed to improving that community. Another one is Watts. We just opened an MOB in Watts that also has a learning center there for locals and a childcare as well. These are not going to increase our revenue in any way, shape, or form. These are commitments to those communities. And we're trying to build a medical, and we will build a medical outpatient facility in Waldorf, Prince George County, Maryland. But it's taking longer to get through the system than the first 2 I spoke about, because we're just not in a place to be able to just build it and without making sure that it's the right size. That we are going to be able to benefit people who are there, but we're not going to overbuild. We are very committed to continuing to do that. I mean, Waldorf is not rural, but it's certainly a community that needs
It's an
to be
excerpt.
served. Yeah.
Right, I mean,
That model's interesting. We're doing the same, call them neighborhood centers, so it's not technically a medical facility. We took over an old Staples building, and we have food pantry in there. You have childcare. Well, you can't officially call that, but there's somebody who will watch your kids when you do whatever you need to do. There's virtual visits can be done there. There's jobs training and all of those other things to serve those communities. So it's not a hospital, but you can get access to some services, which hopefully keep you going in the right direction, and will help with not only food, nutrition, cooking, help you pay your bills, help you pay for heat, help you get a roofer at your house. Like, all of those services are offered through those centers to try to keep those people healthier and out of the hospitals.
We're doing those types of projects as well. We're the largest provider of charity care by 2 times in the state as compared to our competitors. And we're, same type of things Kelly's talking about, and Terry, the food pharmacies, the food pantries, child care. We're partnering with FQHCs to deliver care to the most vulnerable among us.
right? And so those facilities don't sound like anything most of us, right, have typically done, right? You've got child care centers, right, food pantries, right? This doesn't sound like your normal medical ambulatory facility. So it's interesting how this model is evolving and how that opens up footprint possibilities for you, right? You can repurpose space in those communities. So let's talk about that, right? Ambulatory strategy for a long time, you said it, Terry, meant build it. Build it, put it there, they'll come to us. It sounds like ambulatory strategy now is evolving to mean other things, like maybe lease it or repurpose it or timeshare it. So how do you see that evolving over the next 4 to 5 years in terms of going to be more of the same? Yeah, you could
go,
take it
Terry.
first. I'll make everybody answer that question. It's another trick question.
I'd say where we have a large market share, we're going to continue to do the things that we all spoke about here in terms of making sure that it's tested for our model. But we're going to continue to own. We own, we've got with the Risant entity, we're going to have 100 million square feet once that closes. And I would say we own about 85% of our real estate. We're going to continue to, stick to that model. Our balance sheet is still very strong. But where I think I know it's going to change is when we, in, for example, rural markets, we are going to take a different approach to that. Now, if we own the land, I still haven't seen a pro forma where anybody else can build it. For us, our cost of capital is very attractive. We've got a very strong balance sheet. But if we don't have the land, I think we are definitely going to look at opportunities where somebody can bring a proposal to us and do a build-to-suit, for example. And especially as I say, in a market where we're testing, maybe it's a 30,000, 40,000 square foot MOB. It's not a hub or anything like that. I definitely think there's going to be opportunities there because I do think, in fact, I do know that you can build it faster. And as long as we've got purchase options and as long as it meets a standard that's acceptable to us, not necessarily our standard, we have to be much more flexible. We're very rigid on our templates, how it needs to be built, but to some extent that's hurting us. And I think we have to be accepting of a model that is good enough, frankly, as opposed to, I won't call it gold plating, but something that we've gotten used to building over time that maybe we don't need, and especially in a market where we're testing.
Right.
So, and this idea of owning all your infrastructure was, I think, the right approach for clinical facilities. But boy, I've got about 2 million square feet of commercial buildings. If anybody's interested, in some pretty horrible places, and that did not make any sense.
Yeah.
Owning your admin spaces.
Yeah, let's talk about that, right? It's the elephant in the room. A lot of people really like our sector now. And every single one of our clients is shedding administrative space, whether they own it or lease it or trying to. What does that look like? Because that it's not ambulatory per se, but it's also not inpatient. So that is a weight on your balance sheet, and it impacts what else you can do. So I'm curious, you've got $2 million that you want to.
We have more than that. We have, we have 8 million square feet of admin space, 45,000 workers who work in that space. Well, they don't. They used to.
Used to.
They have name tags.
So we came up with a plan that said we can cut it in half. And initially, and this was halfway through the pandemic, and we went through a very, a very lengthy process of determining where and how our employees needed to work. When we came out of the pandemic, during the pandemic, they were all remote, of course. And we came up, our figures were full-time remote were 65%, and it was in the order of 25% were flexible, so they were meant to be in the office 2 or 3 days a week. To me, that's full-time, but that's how they defined it. And 10% were full-time in the office. Full-time in the office were allocated an office, whether it was a cube or an office or whatever. Yeah. Nobody else was allocated that, but the executives were very concerned about that. You're cutting too much. I said, no, we are not. We did the utilization pre-pandemic, and you were using that space 35 to 40% of the time. If we had not had dedicated seats, we could have done it pre-pandemic. And so now we've got a plan to cut it in half. We're going further.
Okay.
We're going to come back to the office more than we are today, but today we're single-digit utilization in those spaces. We need to go further. And the other reason I think we need to go further is we need to get out of all these, and we'll take a hit, we'll take an impairment. We need to get out of these owned facilities that are 600,000 square feet in markets, market headquarters. And the only way we're going to be able to provide the right space for those employees who are coming back is to get a landlord to fit up the space. Because we're not going to get the funding over the next 4 to 5 years to invest in those spaces. And we have some of the worst administrative space that I've had to manage in my entire career, and I managed globally before I came here. So we have to improve the space, make it more collaborative, make it brighter. I mean, a lot of our space doesn't see the light of day. The offices are on the outside, on the perimeter of the building, and it's not even healthy. And so we've got to get out of those spaces.
That's the first problem.
Yeah.
So what about you, Steve?
We've got a pretty robust return to work policy. So our culture is one that's really requires in person, and so we've got. To Terry's point, we're adapting the spaces to make them better fit the way we operate today as opposed to before the pandemic. So we're actually starting a construction project now to add more enclosed offices, the collaborative areas, the open workspaces don't really work in the Zoom environment as much as maybe they did in the past. And so, spending a little bit of money to make sure that the office space better reflects the way that we work today.
Okay. Do you have a remote? Is anybody allowed to work remotely, or
there are certain
departments
departments like thinking IT type work that I don't know that they're ever coming back, but the vast majority of our workers are back in person.
Okay. Oh, you are an anomaly in that regard.
I think it's the culture and the beliefs of the CEO.
I mean, it's really interesting, right? Because for so many systems, that was really a philosophical issue because clinicians could never go home. I had a lot of systems who really grappled with that in the pandemic, that they really were hesitant to allow permanent hybrid work.
I think that's part of it. The physicians and the providers are there every day, and they always have been. And what does that say if
you're not?
Nobody else shows up? So I do think that's part of it.
What about you, Kelly?
Same as what you guys have said, consolidation of the admin space. We do have a health plan, so we cover 4.5 million lives. That health plan team went virtual right before the pandemic, so some of that space needed to be gotten rid of a long time ago. IT also had went remote right before the pandemic hit, so we're trying to catch up with all of that space. We leased it, luckily, so the time will come for consolidation of that. you mentioned leasing and TIs. That's the other part, is even subleasing doesn't really work because nobody wants to be in these buildings.
Correct.
And nobody will come in. And other people will offer $200 a square foot in TIs, and we're certainly not giving that
Right,
capital out
certainly
for
not.
TIs for other people to sublease our space. So it's a hard sublease market too.
Yeah, right. It's really difficult to be shedding space, especially large headquarter type things from vintage 1980.
We need Cushman's help to shed
Yeah.
all this space.
I don't know if Cushman wants to help you with that one or not, but we'll talk offline. I do have a question. This is related, and we did not talk about this, and it's a thorny issue. So if you don't want to answer, I give you a pass. But the elephant in the room and all of this stuff is also physician offices. And I thought that maybe during the pandemic, that might be the moment when you would get this opening to have that difficult conversation about a space where your diplomas hang on the wall, but is otherwise not much utilized. So Kelly, have you attempted to tackle that one?
I've fought that battle and I've not won. But it does come up, interestingly enough, again, to the utilization numbers where they can't get their utilization up, and you realize that every doctor has turned exam rooms into their offices rather than the shared office space they're supposed to be using. And then you can have a very candid conversation about removing your diplomas and turning them back into exam rooms to get their utilization up. That's where it's been
Most successful.
Yep.
So,
Yeah, that's a big push for us, and we are actually having some success. So much so that we're building a 230,000 square foot high-rise medical office building with premier specialties, and there are no physician offices in the building.
Are they shared?
It's touchdowns and collaborative workspaces, but no pictures of the fish and the diploma. It's not personal space.
there's no personal space.
Correct.
Right.
We've done it successfully at one of our children's locations, and what it takes is that group of physician leaders to talk to the others, and that's the problem, is whether they want to listen. Or your children's, so you're different than cardiology. You don't understand my specialty, even amongst our docs.
Kelly made the point earlier in a different context, but that's where the physician leadership is key. If you have the right physician leader saying this is the way it's going to be.
Right. That conversation cannot originate with anybody in real estate or anybody without MD after their name. I was doing a project and I asked my next door neighbor, a trauma surgeon, about giving up his office. And he was like, I cannot give up my office because I have my refrigerator with my Mountain Dew and all of my Steeler stuff. And I was like,
Which is
okay,
against
good.
every policy for him to have his own fridge in there, but that's a whole different conversation.
Okay, I'll let you have that conversation. He, by the way, does not work for Kelly's system, although he would love to because he's a Steeler fan. I think this will be interesting. And honestly, I think every system is waiting for some other system to do it successfully. And as soon as there's one good case study, boy, right, the dominoes are falling. But there's a lot of physician office space in clinical environments that is not well utilized. And if you're going to optimize that space, there's the square footage. So it'll be interesting to see how that plays out in the next 4 to 5 years. I think you all might want to gird your loins for future conversations. Okay, so I think we have just a few minutes, 5 minutes left. So we've got time for one more question unless anyone in the audience has questions. Yes, we have a question.
A question about the capital expenditure plan. You're sounding mostly predominantly hospitals. What percentage of that is on balance sheet versus donations versus third-party capital, tax, and debt financing? Like roughly, how are you funding those big hospitals?
I'm happy to start. I mean, we have some bonds, obviously, that we've taken on over the years, but it's 100% self-funded, and some of that is through the bonds, obviously, that we've secured.
Yeah.
Does that answer your question?
Of the equity piece, is it mostly on balance sheet? Is it
From the balance sheet.
fundraising campaign?
No fundraising campaigns. It's from the balance sheet.
Yeah, we're the same. Though for capital projects, for the first time, our system has opened to donor funding. The last system I worked at, that was part of every single major capital project. It was a donor portion of it. This will be the first time. We're targeting $200 million on a $1.5 billion project for donor funding.
Yeah, it's same. We're funding from the balance sheet cash, and we do take donations. Roughly, maybe 10 to 15% of that, if you're successful, may come from donors. But there's no other financing.
Any other questions? Okay, our final question for you folks is to think about kind of a forecasting question. And as you think about this going forward, right, if I had to ask you to get out your crystal balls, and in 5 years when we reprise this panel at Revista, what do you think will be one new strategy that you haven't seen before, if any? And what do you think will be one old strategy that gets new life?
Kelly, you probably want to start.
I do not want to start.
I would say, I don't know that it's new per se, but more prevalent will be the flexibility that the rooms will have, so that you're prepared for any type of acuity level. We've talked about that a little bit, but having that flexibility that you can flex between uses depending on what's going on the acute care side. I think we'll see more of that if we can afford it to make those investments. And then I guess the virtual front door, I think, is just going to become more and more prevalent. And how can we take advantage of the electronic health records to make a seamless experience for the initial patient encounter? I don't think it's ever going all virtual, but I think you're going to see more and more of that with new generations.
Right, it might be your first encounter. It's not. Do you think it will supplant some of your physical space or reduce your need for it?
I haven't seen that so far.
Right, we haven't seen it either. It seemed like a red herring there that virtual was going to kill the medical office building.
I would say it's going to continue to impact mental health, behavioral health. That's where we've retained those fairly high levels of virtual care, but nowhere else. Everything else has returned to pre-pandemic. But mental health, behavioral health, I think there's an opportunity to, because people seem to be quite comfortable to have their work done, whatever has to be done, virtually. Like they prefer it, especially in the Bay Area, San Francisco, LA. I mean, the people don't want to drive an hour and a half, an hour, or even 30 minutes if they can do it at home. So I think that's something that will be impacted for the longer term. But I still think we have to track, what's going on in the industry. How is healthcare changing? Yeah. I don't know, and we don't know, but we got to track that really closely to make sure that we're not behind it.
Right.
Try and stay out in front of it.
I mean, I think AI is going to be a huge change in healthcare, and we're already seeing that on a lot of different fronts. I also think something that's old that will come back is home healthcare. So not virtual visits, but how much the doctor coming to your house to deliver the care. We have some of those practices right now, and it's obviously insightful if you see the living conditions that your patients are in versus what they tell you when they're sitting on an exam table. Those doctors talk at length about how many other services these people need and how many other factors are playing into their condition that they never disclose in a typical office visit.
Right, so that may mean that you're building more food pantries, right? Yeah. Or childcare centers that are not called childcare centers. Right, if that's what they see, they won't be able to unsee it, and then you're going to have to deal with it.
Right, absolutely.
Kelly made a great comment about AI. I heard somebody said recently that AI is not going to replace doctors, certainly in the short term, but doctors who don't use AI, they're the ones that will stay, and the others are going to fade away, frankly, because we have to use it.
Yeah. Right. And I think it'll help with staffing too. I mean, we can use it for sitters in rooms, fall protection or prevention and things like that, where they can be watching patients without having to have one-on-one attention. So that's where you get those staffing savings and maybe not reduce costs, stabilize some of the labor shortages.
It might also help in some of your more remote areas, frankly. If you struggle for staffing there, AI might offer promise that you would otherwise not be able to cover. So, All right, well, thank you all for a lively and insightful discussion. It was a pleasure. If you have any additional questions, I'm sure you can send them to us. Some of us have to head to the airport almost immediately, so you may have to email your questions to us, but we would be happy to entertain them. And thank you again, Terry and Steve and Kelly, for a really interesting and thoughtful discussion about this important topic.
Thanks, Lori.
Thanks, Lori.
That was fun.